evening, everyone. This is something which is quite interesting and important, especially given what was happening in the last couple of years or so, ARDS. So I think after the COVID pandemic, even if nobody has ever heard of this syndrome before, I'm sure at the end of it, everyone knew what ARDS ultimately was. However, this is a disease which can actually be quite confusing to diagnose, especially when the patient is undifferentiated with regards to shortness of breath. And in all actuality, for the last almost more than a decade, there have been global groups trying to figure out like how to treat this disease, how do you define this disease. It's undergone multiple changes and such. And ARDS in itself can lead to an entire day's seminar. We have about 45 minutes to 1 hour at the end of the day. So I've just tried to make it as simple as I could. This particular lecture is going to go through six different subdivisions. The first one, of course, is the definition. They're followed by the diagnostic criteria, the grading, the pathophysiology and causes, and we will spend a little bit of time on management because that has actually undergone several changes in the last decade or so, and that's what we're going to focus on in this particular lecture. So the definition of ARDS, as defined by the Berlin Subcommittee in 2012, it's on the screen. I'm just going to read it out. It is defined as per that group as an acute diffuse inflammatory lung injury leading to increased pulmonary vascular permeability, increased lung weight, and loss of aerated lung tissue. It also leads to hypoxia, bilateral radiographic opacities associated with increased venous admixture, increased dead space physiologically, and decreased lung compliance. That is a mouthful of words, and I think it kind of makes no sense to a whole lot of us here. ARDS, in simple terms, is nothing but a syndrome of hypoxic respiratory failure associated with non cardiogenic pulmonary edema. So, this actually is a separate entity to something like, say, pneumonia or asthma or COPD, which is again a respiratory hypoxic failure without a pulmonary edema. And there's definitely absence of cardiac involvement here. This is due to a diffuse inflammatory damage to alveoli as a result of a local or systemic insult. So, what this means is you can actually have a disease in another part of the body, say pancreatitis, burns, following trauma, etc. And then suddenly the patient may go into breathing difficulty, which actually is ARDS. So we'll go over the pathophysiology in some detail. Just know that this is basically a hypoxic respiratory failure without pulmonary edema, and which can be set off by a variety of triggers. The diagnostic criteria, again, as defined by the Berlin criteria of 2012, it is marked by the following 4 points. The acute onset, which is within 7 days of any defined trigger, for example, pneumonia, but the causes can be quite varied, as you will see in later slides. The degree of hypoxia, which is measured specifically by what is known as a PF ratio, specifically a PF ratio of less than 300 millimeters of mercury on breathing room air, or at least 5 centimeters water off PEEP. There are bilateral lung infiltrates seen on the chest X-ray or CT scan, and all this is not explained by cardiac failure or fluid overload. So you can't really say some patient has been given a lot of IV fluids or someone has missed their dialysis or diuretic dose and they suddenly present in pulmonary edema. That's usually secondary to a cardiac cause where the heart is overwhelmed and that back pressure goes into the lungs and causes pulmonary edema. This is not from that. So you have to have ruled out pulmonary edema from cardiac causes to make a diagnosis of ARDS. And why is that important? Because the treatment of ARDS is absolutely different to the treatment of cardiac failure. The grading of ARDS is very simple to remember. It's using what is known as a PF ratio. So the PaO2 is calculated by the arterial blood gas bedside test, and it can be classified into mild, moderate, and severe. With mild being between 300 to 200, moderate being between 200 to 100, and severe being anything less than 100. So in the COVID pandemic, when we had PF ratios of less than 180 or even less than 150, that was actually considered a very high uh, chance for mortality in these patients. So the grading can be quite straightforward and is calculated. It is graded and objectively scored based on the PF ratio. So these are just some X-rays I have pulled up. Again, this is from the net. This is not from any particular hospital. What X-rays would look like based on the various degrees of ARDS. The top left corner is what a normal lung would look like. If you look at number B, which is the top right, that's mild ARDS. So you can see there's not too much difference from the mild ARDS to the normal X-ray. However, it gets progressively worsened over time. When you look at C and D, moderate and severe, by the time it goes to moderate and severe ARDS, it looks very much like what we would expect a pulmonary edema X-ray to look like, with a typical back ring appearance and all. But this does have certain radiological differences to pulmonary edema. The main reason being that if you actually carefully observe, you could pinch and zoom in and see the X-rays. The patchy opacities are bilateral and they are not uniform. They are heterogeneously displaced. One may not be equal to the other. And even on things like the ultrasound and stuff, there can be significant differences between the two. Specifically, the B lines which come up on the ultrasound are actually not the same bilaterally. So the X-ray, though it is a very good early screening test for ARDS, it may not be very sensitive, especially in very mild cases. So the CT scan or the HR CT scan is actually a much more sensitive indicator. This is actually a picture of moderate ARDS. So looking at this, you can actually quite objectively see that the distribution of opacities is not the same in both the lungs. You can also appreciate that the majority of the pathology sits in the posterior part of the lung. So that is again a very defining feature of ARDS, where normally you'd expect it to come up in the bases and go up from there. But actually ARDS starts near the back of the lungs and then goes forward. So the HRCT is actually quite a sensitive case screening tool. And again, this was invaluable during the COVID time since X-rays were not very sensitive for early ARDS. The downside of this was we actually had patients who who would undergo like multiple CT scans a day just to look at the instead of taking X-rays, they like be shifted up and down for CT scans 2-3 times a day, or even once every 2-3 days, just to see if the disease is progressing or not. So obviously we have moved on from the pandemic, thankfully. But this is what a typical CT picture of a ARDS, moderate ARDS would look like. So that is about PaO2, is calculated by the ABG. Now, what is FiO2? And the PF ratio, what is F? FiO2, of course, is fraction of inspired oxygen. That basically is your oxygen concentration or how much O2 you're giving the patient. Now, in big ICUs or well-equipped EDs, these are accurately calculated by venturi devices. I'm sure those of you who are working in critical care areas uh, or emergency departments have seen this before. So these are basic devices which are connected to the oxygen mask, and no matter how much oxygen you give the patient, the concentration is titrated very accurately to make sure the patient gets the oxygen that they need. So the blue venturi device gives around 24% of FiO2, 24% oxygen, and that can almost be equated to around 2 to 4 liters per minute if you don't have the venturi device, if you're just using a normal flow meter. The white gives around 28%, and that equates to around 4 liters per minute of oxygen. The orange gives 31%, equated to around 6 liters per minute. So the ones at the numbers at the bottom are the approximate concentrations if you don't have a venturi device. If you just have a flow meter and you're giving it 2, 4, 6, 8 liters per minute, approximately the oxygen delivered to the patient is the percentage on top. And that percentage is the FiO2, which is what we need to do to grade ARDS. Finally, when you're giving the patient maximum oxygen, you've turned the flow meter up to maximum 15 liters per minute delivered, you're giving the patient 60% of FiO2. So that's about the maximum you can go. More than this, you'd have to intubate the patient and manage them that way. So let's just have a small exercise here with regards to grading of ARDS. If a patient with acute COVID infection is brought in, breathing extremely fast, he's also hypoxic, he's got low saturation, He started on the maximum percentage of oxygen in the emergency department. An ABG is taken, but the doctor has to go see another patient. So if the nurse or the technician has to look at the ABG and grade the patient, the ABG shows a PaO2 of around 40. That's the value which is there on the blood gas. So what is the grade of ARDS? We can calculate the PF ratio by looking at 40 divided by 60%. Since we know the patient is getting 15 liters per minute of oxygen, that gives an FiO2 of around 60%. So 60% is zero point 0.6. So 40 divided by 0.6 is 66.67 millimeters of mercury. And if you remember what the grading of ARDS is, less than 100 is severe ARDS. So this patient actually has severe ARDS and requires very intensive care. Talking briefly about the pathophysiology of ARDS, there are three main phases which ARDS patients actually go through. The first is the exudative phase, which is the acute phase where the damage actually happens. There's a release of multiple inflammatory markers from insult which happens somewhere else in the body, and these inflammatory markers, just like any other normal hepatitis or cholecystitis or renal failure, whatnot, these inflammatory markers will enter the systemic circulation and end up in the endothelium of the lungs. Over there, they release reactive oxygen species, which is O2 radicals, etc. And that actually damages the endothelium of the capillaries. So when the capillary endothelium gets damaged, there's edema fluid which actually seeps out. That's protein rich, it's exudative. Again, remember, CCF is always transudative. But this is a inflammatory cause, so it will be protein rich, exudative. So that actually comes between the alveoli and the vessels, and that leads to a non-carcinogenic pulmonary edema. That's the exudative phase within 3 days of the insult. From 3 days to 1 week, because of damage within that basement membrane, there is a proliferation of type 2 pneumocytes. Because, as you know, type 2 pneumocytes secrete a surfactant, which is responsible for alveolar opening and closing and keeping the surface tension of the alveoli strong. There's a proliferation of type 2 pneumocytes to try and repair the damage which was lost, and fibroblasts as well. The last stage, which can go from weeks to months, is when the lung either heals itself or is permanently damaged. If there's a disordered secretion of fibroblasts and there's a lot of fibrous tissue formed, there's permanent damage. Or patient is lucky enough to get the proper care, the alveoli does not have to suffer extra damage, the lung may actually recover. This picture kind of shows the difference between the two. I would invite people to actually pinch and zoom. I'm not going to explain everything over here, don't worry, it's too late for that, and I know people have other things to do. Just know that the left side is what a normal lung looks like. If I can just draw your attention to the fact that the alveoli is there and the blood vessel, the pulmonary vessel, lies just below that, and in between the alveoli and pulmonary vessels is the area where gas exchange actually happens. This happens in a normal alveolus, but you can actually see there's a lot of inflammatory cells coming over there and causing endothelial damage. On the right side of the diagram, you can look at the same place between the alveoli and the vessels. It's full of fibroblasts, fibrous tissue, and tissue, all that stuff. So what that does is that actually gives a barrier to gas exchange. So as we know, when blood from the right heart comes to the lung, it carries deoxygenated blood, and when we inspire air from the atmosphere, we carry oxygen down to the lungs. So this is the point where gas exchange happens. Carbon dioxide from the alveoli comes into the blood vessels, and oxygen from the blood vessels comes into the alveoli. So there's a gas exchange that happens, and that gas exchange actually is hampered because of all the fibrous tissue and inflammatory exudate which is formed. So there's like a wall to gas exchange. So the whole point of treating ARDS is to try and break down that wall and to improve gas exchange. And how do we do that? We will see in subsequent slides. So as I mentioned earlier, the causes for ARDS, it's not so simple as just say a pneumonia or whatever. Anything can cause ARDS. If someone has an aspiration of gastric content, that can cause ARDS. If there are air or fat emboli, so any inhalation of smoke, inhalation of toxic fumes, if the patient has had trauma, then there's a lung contusion that can lead to uh, ARDS as well. Those are the direct lung injury. Ones that actually hit the lung can cause ARDS. Again, remember, within 1 week of the insult, this would happen. However, there are indirect lung uh, trauma agents as well. Any sepsis, septic shock patients, of course, the most common one is COVID-19. But in my part of India, we see a lot of acute febrile illnesses like scrub typhus, and scrub typhus actually manifests as ARDS quite commonly, especially in the severe form of the disease. So you'll have a patient with fever and with the typical signs of scrub typhus, suddenly they go into really difficulty. That's ARDS because of scrub typhus. Trauma itself can cause ARDS. Pancreatitis is known to cause ARDS quite frequently. If a patient undergoes a lot of blood transfusions, they can have ARDS. So practically anything, any insult anywhere in the body, suddenly they have breathing difficulty, which is not explained by a cardiac or respiratory cause. It could be ARDS, and that needs to be treated accordingly. So that is the initial part of the lecture. And as the lecture title is what works and what doesn't work, so we're going to talk about the management of ARDS because that's the most important part. So the misconception is all patients with ARDS have to go to ICU. That's not necessarily true. There are things we can do even in a non-ICU setup, which can actually be beneficial to the patient. I have broken down the management into four different parts: the general principles of management, what is lung protective ventilation, fluid management to these patients, and of course, how do you position them. General principles are we would look at lung protective ventilation and recruitment. What are these things? How do you manage IV fluids for these patients? Do you paralyze these patients? So people who are working in the ICUs and operation theaters would know that often when a patient has to go on a ventilator, they need to be paralyzed. Now, do you paralyze these patients or not? Evidence will say what to do. And we have to actually think about proning patients in severe cases. Normally, patients are nursed or patients are managed in supine or semi-recumbent position. Actually, in severe cases, proning, which is turning the patient upside down on their tummy like an omelette, would actually improve ventilation quite a lot. What is lung protective ventilation? If there is anything you all can take away from today's lecture, I would recommend you take away this point because you cannot manage ARDS without lung protective ventilation. Normally, when we set our tidal volumes on the ventilator or when we breathe normally, we breathe at approximately 10 ml per kg of our own body weight. Lung protective ventilation, actually, they say on the ventilator setting, you should set your ventilator to 4 to 6 ml of ideal body weight. Ideal body weight. That's because an obese person will weigh, what, 120, 150 kilos. You don't want to be giving them that much of oxygen. You cause barotrauma. So, this is the formula for ideal body weight for the different genders. And in ICUs and all that, actually, they have pre prepared tables for 40 kilos, 50 kilos, 60 kilos, 70 kilos. So if the patient is 40 kilos, this is the ideal body weight. If the patient's weight is 50 kilos, that's the ideal body weight. And they can set their ventilators quickly. They don't have to pull out their calculators and calculate every time. That's a low tidal volume. On a vent, when you look at the patient's plateau pressures, you have to ensure that the plateau pressure, which is the flat line which goes like that, is less than 30 centimeters of water. So you need to titrate your PEEP accordingly. So when you increase your PEEP, you can increase your PEEP from 8, 9, 10. Often it goes up to even 12 and 15. As long as it doesn't go above 30 centimeters of water, you're fine. And there's something called as permissive hypercapnia. Now, if you remember our respiratory physiology, we know that the homeostatic mechanisms of the body is makes an effort to send off carbon dioxide, right? We want to maintain that carbon dioxide level beyond a certain point because when the carbon dioxide goes up, there can be issues with the body, etc. But in ARDS management, the concept of permissive hypercapnia actually comes in, where we can actually allow a degree of respiratory acidosis up to a pH of 7.2. That actually is beneficial for patients with ARDS. So we have to ask ourselves, why are we giving the patient low tidal volume? Why are we giving the patient high PEEP? That's because from the early 2000s till now, there's been a lot of studies on ARDS management, as this is a very challenging thing to handle. And multiple studies from all over the world have compared low tidal volume with 10 ml per kgs of ventilation. And they found patients with low tidal volume actually had reduced mortality and increased ventilator free days. Those patients were able to be extubated earlier and sent to the ward without reintubation. And if the tidal volumes are high, the alveolar can actually distend a lot. When they distend and contract, that can cause what is called as volute trauma. So they distend and that releases more reactive species. We don't want the alveoli to actually distend and collapse. We want them just to stay open so that they stay open and they allow gas exchange to happen. If they keep distending and collapsing or they extend too much, that can actually cause alveolar rupture, worsening the condition. So we want to prevent volute trauma, so we keep our tidal volumes low. So that's about the low tidal volume. Why are we giving high PEEP? Normal breathing PEEP, what I'm breathing now, is about 5. Atmospheric breathing is around 4 to 5 of PEEP. So these patients require an additional PEEP or a CPAP of almost 8, 9, 10, sometimes even going up to 15, as long as it goes less than 30 centimeters bladder pressure. That's because when you're giving the patient PEEP, the function of PEEP is actually to keep the alveoli open at the end of expiration. We know that when the patient inspires, when we take a deep breath, our alveoli expand, and when we breathe out, our alveoli shrink. So we expand and we shrink. So at the end of expiration, when we finally finish breathing, our alveoli are collapsed. Now remember, in a normal ventilated lung, they can expand quite easily. But when you have so much muck around the alveoli actually struggle to open like that. So it stays closed, and when the alveoli are closed, gas exchange does not happen. So when you give the patient higher PEEP, we actually force the alveoli open and we keep the alveoli open even during expiration. That allows gas exchange to happen very easily. So it prevents the alveoli from collapsing or de-recruitment. And when the alveoli are well distended, acylatasis also comes down. Because of there's so much edema around it, you can actually physically overcome that edema and allow gas exchange to happen well. And remember, every patient, some require higher PEEPs, some require lower PEEPs. Patients who are obese, patients who are pregnant, patients who are naturally quite big, they require a much higher PEEP than someone who's actually quite thin. And remember, when you give the patient too much PEEP, that can actually cause rupture of the alveoli again and cause a pneumothorax. So you must individualize your PEEP to suit the needs of the patient instead of just blindly following the guidelines. ARDS is a condition which requires a lot of individualized care and very high monitoring. And also remember that as you increase PEEP, the amount of pressure inside the chest actually increases. And when the pressure inside the chest increases, that can actually lead to hypotension because cardiac return comes down. So sometimes when those high PEEPs are required, you would want to start the patient on inotropes or vasopressors to overcome the hypotension and blood pressure. So why permissive hypercapnia? So I'm going to spend a little bit of time on this because this may be a new concept to all. Um, we have all been created in a wonderful way. Our bodies don't want to die. Our bodies want to get better. Our bodies want to stay healthy, whether we want them to or not. Our body is designed to stay healthy in the face of adversity. That's the whole concept of homeostasis. Now, when there is hypoxia, when there is increased carbon dioxide levels in the body, what happens is every other blood vessel in the body actually goes into vasoconstriction and hypoxia, except vasodilation. I'm sorry, vasodilation. That's because when the body is hypoxic, the body tries to increase oxygen delivery to the tissues, and with that, the blood vessels dilate so that the oxygen delivery can be improved. This is the same in every part of the body except the lung. In the lung, the organ of oxygenation, it's the exact opposite. The pulmonary vessels actually shrink when there's hypercapnia or hypoxia, and they dilate when there's good amount of oxygen and less amount of carbon dioxide. How does this help? If you look at this diagram to the left, the lung is actually, it undergoes two different physiological processes. It undergoes perfusion, which is blood which is from the heart going to the lung, and ventilation, which is air from the atmosphere, from the nostrils coming down to the lung. And the lung is divided such that the different parts of the lung, the upper part, middle part, and lower part, are all ventilated and perfused in different quantities. If you look at the leftmost part with the black arrow and the three blue lines coming across, that represents deoxygenated blood from the right side of the heart going into the lungs. And you look at the circles in the center, O2, 1, 2, and 3, you notice that the blood vessels which going up have the widest caliber. The blood vessels going to the base of the lung has got the lowest caliber, which means perfusion actually is least at the bottom and most at the top. And oxygenation is inverse. Oxygenation is more at the bases and less at the top. That's where the circle size goes up. So what happens when you have a lot of deoxygenated blood going to an area with small amount of oxygen? That blood does not get oxygenated. So this is in a VQ mismatch when ARDS actually happens. When a normal ARDS VQ mismatch happens, you have a lot of blood, a lot of deoxygenated blood going to a part of the lung which is not oxygenated. So ultimately, oxygenation does not happen. So you will get deoxygenated blood back into the systemic circulation. But as you go down, you can see there's a point where there's a little bit of flow going to a place with a lot of oxygen, and that little flow gets oxygenated well, and that becomes red oxygenated blood. At the end of the day, the blood which is leaving the lung is mixed. You've got a mixture of venous and arterial blood, which again goes to the left heart, and that mixed blood gets sent to the rest of the body. So oxygen delivery is not appropriate. Our body has been designed in a wonderful way where our lungs actually sense that there are certain parts which are not good, and they try to overcompensate that. So this is called hypoxic pulmonary vasoconstriction, specific for vasoconstriction in the lungs because of hypoxia. So what happens is if the blood flow goes to a part of the lung which is not oxygenated well, that area actually shrinks. So you have less amount of blood going to an area which is not ventilated. So the overall transfer to the left heart is actually much, much less. But all the other blood is actually shunted to different parts of the lung, which is better oxygenated. And that leads to better oxygenation, better gas exchange. So the overall blood leaving the heart actually is well oxygenated. So this is the whole point of hypoxic pulmonary vasoconstriction, and this is what is needed to improve oxygenation and ventilation. So that's why we actually allow a little bit of carbon dioxide because we want those parts of the lungs that are not ventilated to be shut down. We want to close down business in those parts of the lung that are not ventilated. We want to transfer all the business of blood flow to parts of the lung that are better oxygenated so that we can improve the overall patient ventilation status. This is the whole thing with hypoxic pulmonary restriction. I won't go too much into detail on this because you can do your own reading on that. But this is basically what we are trying to accomplish when we are increasing the patient's PCO2. We can increase the PCO2 up to around 60, which is actually very high in a normal patient. But in ARDS, it's found to be beneficial. So that's what we try to do. There is some conflicting evidence on recruitment. I have not put too much of that in slides because it's a confliction and I don't want to be teaching absolutely wrong things here. Recruitment is nothing but increasing your PEEP over 30, where you increase your bladder pressure to almost 40, 50, and just keep it like that for a long time. This again breaks the atelectasis and improves oxygenation. However, when you increase the PEEP so much, you will definitely cause hypotension and you will almost certainly cause pneumothorax as well. So this is a bit controversial. Theoretically, it should work. In some studies, it showed to be beneficial, and some studies it shows no mortality benefit. So I will leave it to you to follow your institutional protocols and go accordingly. But evidence on this is lacking or inconclusive right now. So, how do we give patients IV fluids? Normally, patients in sepsis, we know that we should give the patient a lot of fluids to reverse the sepsis, right? So, a trial was done as early as 2006 called the FACT trial, where this was actually an RCT, a randomized control trial, a very good study, where they looked at patients with ARDS, moderate to severe ARDS, and they divided them into two groups: those who got a lot of IV fluids versus those who got less IV fluids. And they found the patients actually who got less IV fluids had many more ventilator free days and ICU free days, which means they were taken off the ventilator early and they were discharged from the ICU earlier compared to those with liberal fluids. The problem with this study was I actually went through it. The exact volume of fluid was not mentioned in the trial. They didn't say liberal fluids, this is this ml per kg. They just said liberal versus conservative. And uh, what they did mention is patients who had an overall negative fluid balance at the end of the day was considered conservative. I don't really know what the actual volume was, but just know that we would try to give the patient as little fluid as possible, just enough to keep the blood flow going. And if the patient is hypotensive, instead of giving the patient IV fluids, start the patient on vasopressors to keep the BP up. So actually, lesser amount of fluid is better in these sorts of patients. Do you paralyze them? Yes or no? So the good thing with paralyzing patients is they don't breathe against the ventilator, they don't fight the ventilator, and it's much easier to do things like proning and stuff when the patient is paralyzed. The problem with paralysis is you can't just paralyze a patient who's awake. You got to bring them nice and deep, sedate them, then paralyze them, and they end up being on the ventilator much longer because they've got to come off the sedation. They have to fight off infections which may come, all sorts of things. And of course, sedative agents can cause hypoxia, hypotension as well. So it's a give and take sort of thing. So studies actually were shown that there were actually no benefits to any paralytic agent except this one here, cisatracurium. So cisatracurium is a non-depolarizing muscle blocker, which actually is metabolized in a way independent of the liver and kidney. So even if there's subsequent organ damage because of sepsis or whatever, this drug actually is not metabolized by anything. So this actually has been shown to be beneficial in severe cases of ARDS, those who are on a mechanical ventilator for 48 hours of infusion. So, of all the drugs that have been tested, this one has been proven to be beneficial for a short period of time. Although people working in ICUs will probably be shouting at me, saying that NV patients in ICUs are not supposed to be paralyzed. That is true. But this particular paralytic agent, for a short duration of time, has been shown to improve mortalities in patients with severe ARDS. So coming to prone ventilation, I don't know how many members of this group have seen a patient being prone ventilated. It's not a very easy thing to do. It requires one-on-one nursing and needs to be done very carefully, especially when they're on multiple supports, multiple monitors. You can take the patient, turn them over in the bed, and leave them like that for almost 12 hours a day. So, of course, that can cause you've got to make sure the patient's pressure points are well padded, etc. And this is found to be beneficial in very severe cases. This requires a lot of high intensive training. It takes a lot of effort on the nurses' part because they're the ones who take care of the patients. This was actually shown since, if you remember the CT picture I showed you earlier, most of the posterior part, the posterior alveoli are involved. And prone ventilation actually kind of takes the pressure off that because when we lie supine, the alveoli at the back cannot expand because we're lying against the bed. So the most diseased part of the lung is not allowed to expand. You turn the patient prone, they can actually expand much, much easier. It also takes the pressure of the heart off the lungs, so lungs can expand better. It helps with the drainage of secretions, etc. And actually, during the COVID pandemic, what we found was patients who were not very sick but who did not require NIV or ventilator, we would actually in the EDs and the wards, this was very beneficial. We actually made the patient sleep on their stomach and just put nasal cannula on them. And they actually did very well because the posterior parts were able to come off the bed and they could be recruited much more easily. So during the COVID pandemic, actually awake ventilation helped keep a lot of patients off NIV. But in ARDS specifically, this has been shown only to be beneficial in severe cases. And this is not to be done in any place except the ICU. So this is a picture of a patient with prone ventilation. So as you can see, multiple monitors, multiple supports. And let me just put this question to you guys. What if this patient had a cardiac arrest? How can we give chest compression? Someone has to run in, turn the patient upside again, and the patient is ventilated. They've got to make sure the tube doesn't come out. It's a big mess. So this requires very intensive nursing. Obviously, busy ICUs may find this difficult to do. You need one-to-one nursing specifically. But this again was proven to be beneficial in severe cases of ARDS. There have been a lot of therapies which have been tested. None of them have been proven to be beneficial. There's something called high frequency oscillative ventilation. This was actually used in the early stages of ARDS when I was an intern. Some of our patients actually were put on this. It gives a very low volume but extremely high pressures and much higher respiratory rate. It'll be like a machine gun going off here. So they'll go like that. So that actually was shown to increase mortality by two very well documented trials, Oscar and Oscillate. So HFOV is now out. There is some benefit in pediatric patients, but in adult patients is absolutely out. ECMO, something which is now the up and coming brand new thing. Those in corporate hospitals will be very excited to do ECMO. So ECMO actually was also shown to not be beneficial by the EOLIA trial. It's also very difficult to do. There's some benefit in pediatrics again, but not no benefit has been shown in adult patients. It's extremely expensive, uh, full of complications, and it's just not worth the effort. There were various drugs which were tried, like inhaled nitric oxide, inhaled prostacyclins, beta-2 agonists like salbutamol. They tried treating it like they treat an asthma patient. There has been no benefit proven, and there is not a beneficial therapy at all. There is some controversy on giving steroids. Technically, steroids do bring down inflammation and reduce fibroblast proliferation, but steroids also increase the chance of infections from the hospital, and they make your sugars go out of control, which could again be worse. So this has been noted to be controversial. Further studies are required, but none of these therapies are beneficial. In short, the only techniques which have been proven to be beneficial in ARDS are four things: lung protective ventilation, less amount of IV fluids, prone positioning in severe cases, and paralysis with cystocalcurium for moderate to severe cases. So, meta analysis done all around the world by the ARDS group, which is monitoring this every year, show that so far only these four modalities have actually proven to improve mortality rates and reduce ICU stay. And I want you all to notice something very interesting. In none of these guidelines are antibiotics given. That's because this is not an infection. This is nothing but inflammation of the space between the lungs, which is causing decrease of your gas exchange. So antibiotics really have no role here. Your only aim is to keep your alveoli open, give good amount of oxygenation, reduce uh, blood flow to areas which actually have less amount of oxygen, hypoxic pulmonary vasoconstriction, of course, and prone and give systemic as required. Antibiotics are not required for management of this unless there's evidence of infection, like a hospital-acquired pneumonia or UTI or an infective cause which is set off the ARDS. Then you'd need antibiotics. But to treat ARDS per se, say secondary to pancreatitis or whatever, you do not need to give antibiotics, and you should not. Just three take-home messages. Just to recap what you've learned, ARDS is a non-cardiogenic pulmonary edema which has multiple causes. The treatment aims to improve oxygenation, to bring down lung collapse, to improve ventilation perfuse mismatching, and to prevent trauma and barotrauma. And everything which has been discussed about lung protective ventilation is the most important modality in patient recovery. So that's low tidal volumes, 6 to 8 ml per kg, high amount of PEEP to maintain a plateau pressure of 30 centimeters of water, and hypoxic pulmonary vasoconstriction, which is guided by repeated ABG uses. You'd want to take repeated blood gases, look at your pH and PCO2 to make sure that all that is there. Yes, permissive hypercapnia, Dr. Kiran, exactly. So, thank you. So, this is a picture of acute lung injury. And I'm sure many of you kind of know the terminology ALI, acute lung injury. That has now become out of date. The term ALI is no longer used to describe ARDS. So, that's my time. Thank you.